Hello, good evening, good afternoon, good morning, everyone. Um, yeah, it's not a Sunday, it's a weekday. Yeah, so first of all, we are very sorry. Last Sunday, we didn't have a recorded version of what we did, but so we experienced a problem with technology. And David and I, with the little IT that we have, we couldn't recover the videos. We had a problem with the internet. But no problem. So we decided to do this um, so that if if there is anything, sorry, let me do something here. Yeah. So I decided to record for you guys what we went through last Sunday because it was very interesting. So we thank Dr. Seba for coming here and discussing his case. We know he's very, very busy. He's a resident. There are a lot of things going on. This is it mid or late second semester? I even forgot, although I'm calling myself resident five, five, I don't know. Resident six, I don't know. But yeah, I'm still a resident, maybe resident six. Yeah, yeah, resident six, something like that. So last Sunday we had a very interesting case, and I'm going to go through it, going to teach a bit about it, and to reiterate what Seb and Dev talked about in that case. So we had a 67-year-old female who presented with a transient loss of consciousness. So when Seba heard about this, he quickly translated it into syncope, which was very okay. But one thing that he cautioned that be careful when you see transient loss of consciousness, it can also be a seizure. And there are points for and against each in this category, but it is not as easy as it is thought. For example, you usually know that people with seizure, they fell down, they have convulsions. But let me tell you something: convulsion can even occur in syncope. I've seen a video. It is a research that was done in Germany back then. It was so unethical it can't be repeated. If you go into YouTube, you can see it. These students were made to get a syncope. They were told to breathe in and out deeply and then squat several times. When they did that, they had a syncope, they passed out, and some of them were having a seizure. So you can have a syncope and have a convulsion. So it's not a convulsion doesn't mean completely. It's more likely to be a seizure, but not 100%. It can also be a syncope. Also think of tongue biting. Uh, People with a seizure will bite their tongue, but also if you have a syncope, you fall and you hit your jaw, you can still have tongue biting, but there will be a difference. People with a seizure usually tend to bite their tongues on the lateral side, but people with syncope will bite their tongue on the tip, the longer side. So make sure that you patients that are telling you they uh, they bite their tongue, but you examine the tongue and see like where exactly did they bite their tongues. So other points includes something like postito stage. So yeah, people with seizure, when they woke up from a seizure, they are drowsy, they are confused. But even if you have a syncope, you fell down, you hit your head, you can get you can get some sort of a head injury, and when you wake up from that, you can still have some post something that looks like a postito state, right? So that can't rule it out. Urine and fecal incontinence. Yeah, so people with seizure will have incontinence, more likely. But if someone is walking to their toilet and in between they have a syncope, they can also have urine incontinence. It doesn't mean they have a seizure. So yeah, you just go like you consider one, but you don't completely rule the other. It can also be another one. Another thing is, if it is recurrent, it can be a seizure. Yes, seizures, epilepsy, untriggered seizures, recurrent. But if someone is, let's say you have an arrhythmia which comes now and then, you can have multiple syncopes over time, right? Yes. So we will consider both. But Seba uh, went into this, and then he he thought he didn't have the schema for syncope, but I realized no. Seba was just saying that he was so humble, saying I don't have a clear schema. But as we listened to him, we realized he was making a lot of sense. He told us about a different cause of syncope. So I will translate what he said, and then I would add my teaching. I have mine, which is I find it simple to remember. You know, syncope. What happens during syncope? So the body is so like it is so like the brain first of all is so selfish. So the body is like a barrel of blood, and this blood, the brain makes sure that it reaches it. So if there is a little bit drop of blood pressure, so blood doesn't reach the brain properly, the brain tells the body like to fall down. So if it falls down, blood reaches the brain, and then the brain says, "Okay, I have my blood. Wake up." That's a syncope. So syncope can also be translated as transient hypotension. So your schema of hypotension can be a schema of syncope. Simple. So think of blood pressure. Blood pressure is equal to cardiac output times total peripheral resistance. Cardiac output is equal to stroke volume times heart rate. So any change in heart rate, total peripheral resistance, which is the vascular tone, and stroke volume, they can all cause syncope. Let's start with the easy one, total peripheral resistance. So if you have a loose vascular tone, like you have a decreased sympathetic tone, you have a syncope. But if you have the opposite of it, an increased parasympathetic tone, you also have a syncope. So what are the things that can cause a decreased sympathetic tone? Medications, diseases that affect the sympathetic drive, like diabetes mellitus with neuropathy, or Parkinson's. What are the things that can drive up the parasympathetic tone? Carotid hypersensitivity, carotid massage, or like seeing the sight of blood or something scary and then you pass out. So that's easy. If you go to the heart rate, so anything that changes the heart rate can also cause a syncope. So we're talking about arrhythmias here. The arrhythmias can be tachyarrhythmias, a lot of them, and then they can be like bloody arrhythmias. Also, a lot of them they can also cause syncope. So of importance, we should talk about stroke volume. So if you have volume down, you can have a syncope, and volume down you can be either by diarrhea or vomiting or bleeding. You have upper GI bleed, or you have an injury and you bleed, or women have menses and they bleed a lot. They have a syncope. So that can happen. But on the other hand, the blood volume can be normal, but the blood is being obstructed to reach properly different parts of the body, including the brain. We're talking about people who are having aortic stenosis, hypertrophic obstructive cardiomyopathy, things like pulmonary hypertension, which goes along with pulmonary embolism, and maybe uh, you have cardiac tamponade, so those sort of things. So if you go in that manner, you won't lose track of a lot of causes of syncope, and it's a train of thought. So let's see a bit of HPI, and so this patient was previously healthy until that day that she was walking to a market. She suddenly lost consciousness. After 2 minutes, she regained it. There were no convulsions. She didn't report postictal state after waking up, and she denies incontinence. The things we are talking about, trying to figure out is it seizure syncope, but it turns out it's very hard. And so, yes, past medical history was important. She was hypertensive. Dr. Seba reminded her to be careful because we have to look at the medications of this patient because hypertension meds can also cause syncope, which was very nice. And then on general exam, she was well, but the vitals were normal except she had a tachycardia, which standing alone as a tachycardia doesn't do anything. Patient maybe is sympathetic drive is elevated. She's scared. She just has a syncope and she's lying there at the EMD. So we didn't talk much about it, and the exam was completely normal. But when we came to the labs, we saw that the CBC had a leukocytosis of 13 with neutrophil predominance 8.9. David made a very important topic, and I use this. I used to talk to doctors this, but it's so hard to convince the doctors about this. That leukocytosis doesn't mean infection. It's never mean infection, and it's not an indication of an antibiotic. So David made a very important point. For example, this patient has leukocytosis, but look at the history. If you think it's infected, where is she infected? So hard. So sometimes maybe you say you don't know and you wait. They say if you watch Dr. House, by the way, time is the best diagnostician. Like someone presents leukocytosis of 13, a day after they have a painful, warm, swollen leg, it was cellulitis. So you start proper antibiotics. And even if there is leukocytosis and you think it's an infection, what if it's viral? Which one are you doing? I will give you. I will give you Cipro or Vanco. So you don't know. You have to know. You're dealing with a UTI or dealing with meningitis. That's how you're giving you antibiotics. So we should emphasize this in our hospitals. We should reduce the use of antibiotics too much. Everyone leukocytosis, they have a flu, they get subsheltered. Yeah. So I loved that point from David, especially coming from him. But other labs were like dyslipidemia, not so much important here. But so we moved on with the case, and she still had a sinus tachycardia. And at this point, is important. You have to consider what is happening. Why is she having sinus tachycardia? So you put this patient on EKG, it's just showing just sinus tachycardia 108, otherwise normal. You shouldn't worry about it unless there's something else, you know. And so this patient got admitted in the hospital I was working, and then on the next day, she reported a new thing. She reported that now she was experiencing a new cough, which is productive with whitish sputum, and it was associated with chest heaviness when she walked to use the bathroom. But there was no fever, no difficulty breathing at rest or when lying flat. So we ordered a chest X-ray, and the radiologist told us that he was seeing infiltrate in the right lower lobe. So his conclusion was this is a right lower lobe pneumonia, and patient was started on community acquired pneumonia medications, amoxicillin to cover for typical and atypical organisms, and then a dexamethasone was added on it because I think someone thought maybe it was COVID. Maybe at this time they were seeing patients with COVID around. Many hospitals you don't have the tests, and then if you have a suspicion, you just dash out the dexamethasone. Not as safe as it is thought, by the way. Topic for another day. So yeah, that was it. But if you start looking at this case, you guys okay, you're treating pneumonia, but things that didn't make sense. Someone was walking, fell down, come in the hospital, normal. The next day, DIB, excisional, and then chest X-ray shows infiltrates. What kind of pneumonia is that? Why didn't she mount fever? Yes, we understand some patient can't mount fever, very old patient, immunocompromised patient, patient on immunosuppressive medications. This patient was none of that. So at this point, the clinician that we are seeing, actually, the clinician we were seeing this patient, we should have paused and ask that other questions. What is happening? And trying to do other things. But so day three in the ward, patient reported worsening of symptoms. Now the chest heaviness she was experiencing is being addressed, but there was no chest pain. So at this moment now you realize completely this is not pneumonia. Why should pneumonia present like this? Never, right? So you have to pause and ask what is happening. And at this point now, you have to activate your schema for dyspnea. And as we have talked here many times about dyspnea, so dyspnea, 90% of the cases of dyspnea will have their diagnosis coming from the lungs or the heart. The rest is a little bit, the 10%. And these include the three A's, like anemia, acidosis, anxiety, other rare things like obesity, hypoventilation syndrome, or some sort of neurological disorders with weakness of the chest muscles. So these are just 10%. A lot of the things have to come from the cardiac or the respiratory system. And if you go into the cardiac, for example, there are a lot of structures that can be affected and cause dyspnea. And so we're talking about stuff like from outside, for example, you have the pericardium. So the pericardium itself, someone had previous TB, pericardium is so stiff, constrictive pericarditis. Inside it, you can have fluid sitting there, pericardial effusion with tamponade. You go further, you find the muscles. Muscles are weak, heart failure, HEF, REF, HEF, PEF, whatever, but heart failure. You go inside, you find the valves and disease of the valve, subacute bacterial endocarditis, or maybe someone had things like rheumatic heart diseases, very important around here. But if you move from the heart, you go into the lungs again, a lot of causes. And the lung is of particular importance here because you're seeing infiltrate. Those infiltrate are calling that, hey, something is wrong with me and probably not the heart. Or even if it is the heart, it is connected with the lungs. So in the lungs itself, you start outside, you have chest wall muscles, they can be affected. You go inside, you have the pleura can be affected. You go inside, you find the pleural space, it can fill with whatever thing you could have seen in chest X-ray, by the way. You go inside, you find the alveoli can be filled. There are interstitium. In the interstitium, there are blood vessels. Someone can have a pulmonary embolism. And you go further into the center, you find there are the conduits, diseases of the respiratory airways, asthma, and the lights. So that's where we are. So at this moment, this patient needed evaluation for cardiac or for heart. Heart is easy, so we should have started with it. And so we ordered an echo and Doppler. The echo showed that it's dilated right side of the heart with a moderate TR. There was right ventricle impaired systolic function. And so the left ventricle impaired diastolic function also was there with a preserved ejection fraction. But the Doppler ultrasound of the both limbs was normal. So at this moment, you realize there is there is there is a problem with the right side of the heart, which means either it's an isolated problem or it reflects something that's happening in the lungs. Why should there be an isolated problem of the right side, like in this patient? Less likely. So, with the infiltrate of the lungs, this is the disease that is coming from the lungs, and what you're seeing in the right side of the heart is just an outcome. At this moment, Saber thought it was a pulmonary hypertension, which is correct. But David had to pull back Saber and told him, no, remember, yes, it's pulmonary hypertension, but this patient was normal, just fell down, and everything started there. And Saber thought, aha, we must be dealing with a PE, and we have to investigate for that. And yeah, so what was done, even this patient was sent, he did a CT pulmonary angio of the chest, and it was in keeping with the pulmonary embolism. So I took care of this patient, and I saw this patient, I think, on the second day, yes. So on the third day, when I suspected CTPA, when I suspected PE, I immediately ordered her to be on therapeutic Lexen. She weighed 120. So don't worry, that's a dosing. 1 milligram per kg, 1 milligram per kg without caring what's the weight. Just give them that, no problem. And I sent her, they did the CTPA. So after CTPA, we had to go back to the radiology guys. We told them, we're seeing a CT, we're seeing a pulmonary embolism. You have to repeat the ultrasound, and they repeated it, and it was positive. Yeah, this happens a lot. And so we initiated um, this medication. This patient, we kept her on rivaroxaban then, but her DIB just dissolved on the second day of the treatment. It's amazing how these things work. Yeah, so and we thought this patient has to be on lifelong rivaroxaban because of it was there was nothing that we thought uh, triggered this PE. So it was so silent. It has to be a lifelong unless there will be a recurrent rate is high. So we had some teaching points here. A lot of them we have talked about. Syncope and seizure we talked about initially, but yeah, this case teaches us that you can be able to make diagnosis earlier than we did probably. When you saw syncope and tachycardia, you should have questioned what is happening. This should have brought a pulmonary embolism diagnosis even before patient developed that difficulty in breathing. But it's hard. Sometimes I've been in positions where I thought of PE and sent patient to do CTPA and there's nothing. And okay, some people have told me they've been in a position they thought something else they were treating. Turns out patient had a PE at the end. So yes, many patients will have non-specific presentation, but some patients will be even asymptomatic. They just die, or they just come to you, they are gasping and they die. You realize it was a PE very later. But common presentation include difficulty in breathing, chest pain, cough. Again, arrhythmia and pre-syncope and syncope can happen, but are less common. They only occur in less than 10% of patients. The pathophysiology of syncope is thought to be maybe there's transient arrhythmia as the clot is passing through the heart, or maybe when it is passing through the pulmonary valve, it causes transient obstruction and someone passes out. So labs are very non-specific. You can have a high white count. Imagine that white count that you saw. So white count infiltrate, you can think it's an infection, but hey, it is not. High white count can even be there in PE. I don't know why, but it's there. ESR can also be high. Lactate is understandable. This has to be a type A hyperactinemia because of ischemia. LDH can be high. AST, troponins. The EKG is very non-specific, but sinus tachycardia and non-specific STNT changes, these are most common findings of the EKG. This patient did sinus tachycardia. The chest X-ray also is non-specific abnormalities. The Hampton Hams and the other two that I don't even remember their names, they are very rare. If you see them, yes, consider PE, but you shouldn't be looking for them. If they're not there, it doesn't mean there is no PE. Just do know your Wells score, do your the dimers, high index of suspicion, do CTPA. It won't hurt. It will save a patient. Yeah, so that was our case, and I have another approach here for syncope. You can divide them into reflex syncope, orthostatic, and or cardiac. Reflex syncope, vasovagal syncope. You know this, or situational, or others like cognitive hypersensitivity syndrome. Orthostasis. Yes, Seba also made a important point in this. He asked me whether I did orthostatic pressures, like taking pressure during lying flat and then taking pressure when standing up, which I didn't. So bad of me. But yes, shows that Seba can recall these important things because you see here there is orthostasis. So autonomic dysfunction like neurodegenerative diseases like Parkinson's can also cause orthostasis. Meds like alpha blockers, blood pressure medications, and tricyclic antidepressants can also cause this. Others include when patients are hypovolemic or they are postprandial, recognized as postprandial hypotension. Cardiac causes is very important. Um, AV block, SVT, VT, these are arrhythmias. And then you have structural causes like aortic stenosis, cardiac tamponade, pulmonary embolism, very important, the topic of today, or hypertrophic obstructive cardiomyopathy. Yeah, so this was our case last Sunday, and decided to share it here. If you didn't attend it live, you can learn and realize what happened. But I would urge you, if you have time during Sundays, come and let's hang out. There's a lot. You can teach us a lot. We learn a lot from you guys. So, yes, next Sunday we're going to have a case. Please welcome. Thank you very much for watching. Bye.